Hello, my name is Shahada Bulanain, and I'm the correspondent for MedEdge MEA at the 7th Emirates Pediatric Hematology and Oncology Conference in Abu Dhabi. I'm very honored to welcome Dr. Shantu Sin from India, an expert in pediatric hematology. Thank you, Doctor, for being here and welcome.
Thank you. Thank you so much for having me on your show. It's a real pleasure to be back here again.
Yeah.
And it's always nice to be here. I love Abu Dhabi. I loved it the last time, and again, I'm kind of enjoying being there.
How are you finding the conference?
The conference is really good. I think the quality of the lectures, the speakers, it sets an entirely different level. The kind of type of science that is being discussed and the way you have experts coming from across the globe and talking about it. I think it's an honor. I think it's a privilege to be here, even sitting in the audience and listening to those world experts talking about.
It's fascinating the amount of knowledge that's being shared. Absolutely. Thank you. Can you kindly introduce yourself to our listeners?
Hi, my name is Dr. Santanu. I am a pediatric hematologist, oncologist, and basically I'm a stem cell transplanter. So I work in India, in Mumbai, in a corporate hospital called Kokilabhen Dhirubhai Ambani Hospital. I lead the transplant team there. I set it up about 15 years ago, and I'm the head of the department there. That's
Thank you very much. Now let's dive deep into idiopathic thrombocytopenia purpura. If you can briefly explain that to our patients and how does it present in children?
right. So it's a condition that basically what the whole story is in its name. So it's called idiopathic thrombocytopenic purpura, which is just a fancy way to say what we know about the disease. Idiopathic kind of meaning we don't know what's caused it. Thrombocytopenic means the platelets are low, which is what we see.
Right.
And purpura, that you got spots on your body. So all that they means is due to whatever reason the platelets are low, and that's why you got lots of spots on the body.
Yeah, it makes sense. And the presentation is the spots.
The presentation is basically an otherwise very well child who's happy, was playful, doesn't have a care in the world, and suddenly the parents notice that he's got these spots all over his body. He might have a few bruises on his legs where he's fallen down. They get worried, they come to the doctor, and he says, well, everything's normal, let's do a blood count. You do a blood count, and you find the platelets. The platelets are the cells which are responsible for basically making sure our blood flows well and it doesn't clot. And you find that the platelets are very, very low as 10,000 or 50,000. And that's when you kind of say, okay,
A warning sign.
exactly, then this is what we are.
Look, and for the treatment part, how did the treatment of ITP evolve in the past decades?
Okay, so one thing to say about ITP is that it's a disease in which many patients actually do not need a treatment because it happens that due to whatever reason your body makes some antibodies which destroys these platelets. But the body also has a way to repair itself. And what can happen and what happens in roughly about 3/4 of all patients is the body gradually manages to repair itself, doesn't make these antibodies to destroy these platelets. So if you wait and watch, then the platelets can spontaneously come up and be normal. So the first line of management is rather than being wait, you just wait and watch. Masterly inactivity, you just wait and maybe it'll get better.
Right.
But then again, couple of days, things are not going well, counts are going down, parents are worried, and you are also worried as a physician. That's when we start thinking of treatment. And the traditional two ways of treating these patients has been using a drug called IVIG, intravenous immunoglobulin, and it's a blood product. And the way it works, you kind of give it, and that blocks all these antibodies and doesn't let the platelets get destroyed. Or you use steroids. And these two always has been a way.
The first line, yes.
Exactly.
Are there any newer therapies?
Is because these agents are good, they're useful, but then steroids
Right.
has
Side effect.
exactly.
That's
And the longer the patients are on steroids, you have problems with mood swings. One of my parents used to say, whenever you put my child on steroids, my absolute angelic child becomes a devil in disguise.
right.
Yeah, that happens. You got a lot of mood swings. You kind of weight gain. you have more infection. So
It's not sustainable.
it's not sustainable. It's not great. And thankfully, we have a new class of agents that we have now called TPO antibody TPO. And what it does is it actually works uh, to increase the platelet count. And it has brought about an absolute paradigm change because before we only had two options to play with. And now what we do is if we find that patients are not responding or having too many side effects, we put them on this new class of drugs, romiplostinil, Purpura, and we almost immediately see a change. We see the platelet counts getting better and better.
That's wonderful achievement. It's a huge
Change.
Yeah, it's a huge. Did you face any challenges possibly in the transition to those newer therapies?
Yes, because like any new therapy, when it first comes on the market, it comes at a price point that can be difficult for some patients who do not have access to either free healthcare or insurance-based healthcare to actually access the drugs at that. But like many other medications that we have with more use, it has actually come down to a point in its price where it's accessible to almost all patients.
That's good news.
Yes. But more than that, it's that there's been more knowledge about these drugs. So people and professionals are prescribing it, and we can see it. There are some issues here and there with the drug side effects, but nothing that's very serious.
Okay, that's good. With increased awareness and the accessibility, there's always hope to get everyone treated and cared for. Finally, looking at the future, where do you see the treatment landscape of ITP in the next decades to come?
That's an interesting question. And so to carry on with what I was saying, that with this new class of drugs, what we can see is that the patients, while they're on it, the platelet counts are normal. But they need to be on this drug for quite a long time. And we're talking about quite a long time in terms of months. It might even be years, 2 years, 3 years.
It's a long commitment.
It's a long commitment. And sometimes you have this chronic disease, which means you might be on for a decade, really. And like everybody else, we want to put a line through it. You say, okay, this is it. You don't need to take it anymore. And we do try to reduce the drug with such patients, and sometimes we are. But honestly, we need a treatment. And so there is a treatment on the horizon, which again, if you've been following the conference, you've been hearing about CAR T cells, the type. And the way CAR T cells work is that they kind of take out the B cells. The B cells are the ones that causes leukemia. So hence CAR T has been used in leukemia. But the B cells are also the ones that makes these antibodies that causes ITP. So theoretically, maybe not now, certainly not now, but 5 years down the line, 10 years down the line, we may actually devise a CAR T that can specifically go and target a subpopulation of B cells that makes these antibodies. Then you can give it one shot treatment, ITP could be gone forever. Exciting days.
No, that's a great goal and hope. So let's hope innovation takes us there one day. Absolutely. Thank you very much for the great insights, Dr. Sin. It was lovely having you.
It's a pleasure.
We learned so much from your experience.
Thank you. Thank you so much.
Have a good day.